Hope Cook with Dermcast.live. Today we have Dr. Kathie Huang, who has a hair clinic in Boston, Massachusetts, and also teaches medical students at Harvard Medical School. Welcome, Dr. Huang.
Thank you for having me.
So you just gave amazing lectures on hair loss. We're in San Diego. And I would love for you to give us some tips on, let's start with telogen effluvium, because especially since COVID, we see so many patients who come in and they've got their ball of hair and they're crying.
Oh, yes. Oh, yes, yes. Yeah, I feel like telogen effluvium has really taken on a new meaning since the pandemic, especially because after COVID, people have been recognizing they're under a lot of stress. They might have had infection. People are more aware if they had the flu or COVID or some kind of viral illness with fever, and all of that can trigger telogen effluvium. And so telogen effluvium happens 3 months after the trigger, so often patients come in not remembering that something like that happened. So just trying to remember that timeline. Okay, so your hair loss started in January. What was going on in October or September? Those are the key questions you want to ask the patient.
And then do you reassure them, how long, if they say, how long is it going to take to get my hair back? What do you tell them?
Yes, that is the burning question they always have. So typically in a textbook, you might read that it's 3 to 6 months of shedding. But I find that in reality, it might be 9 to 12 months, sometimes a year and a half before the patient feels like they're back to themselves again. Okay. So I always tell them it's going to take time, and it's going to happen in small stages.
Yes. And do you order blood work?
It really depends on what the history dictates. So sometimes they have symptoms that sound like a thyroid could be involved. So we might check thyroid function tests, CBC or ferritin. It's not necessary that all the patients coming in with shedding needs to have labs drawn, but that is something that, based on the history, if it's indicated, we might check for that.
Okay, and they say, is there anything you can do to fix this?
That is the tricky thing, because all our treatments that help grow hair take a long time. Often it takes 9 months to a year. And in 9 months to a year, the telogen effluvium hopefully will just resolve. So I try to encourage people to wait patiently. Now, if they had hair loss prior to the telogen effluvium, already felt unhappy about their hair, then we might think about doing some long-term treatment. But all the growth types of therapy and hair loss require long-term treatment. So I don't like to jump on a long-term plan for a short-term problem.
Right. Okay, and do you give them anything topically, like any compounded stuff?
So the problem with, for example, topical minoxidil is it can induce some shedding ahead of time.
Oh, and then they're really going to freak out.
Right. So I try to give them reassurance. And usually the way I manage that is, if they're emotionally able to handle waiting, then I just have them check in 9 months. And I say, you just come in 9 months and we'll evaluate again. And if it still seems like this is going on and you're ready to jump on a medication, I will help you through that at that time.
Gotcha. Okay, what about surgeries and other causes besides a viral illness? What else do you see, medications?
Yes, medications, sometimes just changing someone's birth control, sometimes surgery. That would include, if someone had hip surgery, and then sometimes they have shoulder surgery 6 months later, so that might prolong the telogen effluvium. Emotional stress, and sometimes that's something very stressful, such as a divorce, death of a loved one, something significant, not just everyday stress. And so those are components of the history I'm trying to elicit when someone has telogen effluvium.
And you really have to be a detective. You have to spend the time asking those questions.
Yes, yes. And a lot of times we can't solve the mystery while they're there. So I usually say, go home and think about this, and you might come up with a reason that that might have triggered this. And if there is no trigger we can find, it still doesn't change the diagnosis. It just sometimes makes it feel less satisfying, because as humans, we always want an explanation, and sometimes we can't find one.
Yeah, and I like that you tell them it's going to take a while. By the time we put you on something that could cause hair shedding,
yes,
and by the time it kicks in, your hair probably is going to be regrowing anyway.
Yeah, exactly right. That sometimes treatment is a worse option for the patient.
Yeah.
And if the patient says that they don't mind being on a long-term therapy, then I might start it. But I try to put it into context of their whole life, and that this should be a temporary measure.
Yeah, I like that. Okay, so what about androgenic alopecia?
So androgenetic alopecia, the new exciting, or I should say it's been around for several years now, but is the use of oral minoxidil.
Yes.
Because it's FDA approved as a topical formulation of minoxidil, but there are a lot of reasons patients don't like that. You know, either they can't tolerate it, or it's too messy, it changes the texture of their hair because there's a product left in their hair. And with the ability to have low-dose oral minoxidil, they can have sometimes better results. They can avoid all those struggles with topical. And patients are really happy, I find, on medication that can help them grow hair. So that's been really a nice addition to our treatment, kind of treasure chest of treatments.
All right, so what dose do you do for females?
So for females, I typically start with 0.625 milligrams.
Wow.
That's taking a 2.5 milligram tablet and cutting it into quarters. Sometimes I start straight at the 1.25, which is half of a pill. And the reason I do that is because at this point I've prescribed so much oral minoxidil, I've seen almost all those side effects. And so I really respect this medication. I know that it can have side effects, and I like to start slowly and monitor as time goes on and increase as the patient needs.
And so how often do you see them after you put them on that initial dose?
Typically, I have them check in 3 to 4 months.
Okay.
Sometimes that's a visit, sometimes that's calling me, sometimes it's a virtual visit to monitor those side effects. And then I would see them, if they're doing well and they're continuing, I might see them 9 months after that.
Okay.
If we're changing the dose, I might check in 6 months after changing the dose.
And what about men? What dose do you start with men?
For men, depending on their urgency of wanting to ramp up, I might start them at 1.25, which is half of a 2.5 milligram tablet, or sometimes I just start at 2.5 milligrams. And the top dose for men, I don't go higher than 5 milligrams in general.
And you said you don't check blood pressure, but you do ask them some low blood pressure type questions.
Yes, exactly. So if there is a concern about blood pressure, sometimes we check the blood pressure, but mostly I ask them about history of, do they have symptoms of low blood pressure, such as lightheadedness or dizziness, or standing up and feeling lightheaded, or history of fainting.
Okay.
So I usually try to ask about that. Now, if someone has high blood pressure on high blood pressure medications, then it takes some coordination. Then I always have to check in with whoever's prescribing those medications for them.
And what factors would keep you from not giving it to a patient?
So for oral minoxidil, if someone already has baseline edema, that is a reason I try to shy away from the medication. I really encourage topical because I'm worried about worsening that edema. If they do have a history of fainting and a lot of low blood pressure symptoms, I really try to shy away from it as well. If someone is soon going to try to get pregnant, that is a reason to avoid oral minoxidil at that time. And if there are any medication interactions, or if they're on other blood pressure medications and the cardiologist or the primary care doctor has any concern about adding oral minoxidil, of course, then I would avoid it in these situations.
Okay, and do you ever combine finasteride and oral minoxidil for men or
Oh, yes, all the time.
women?
Yeah. So usually I like to start with one drug and see how they do. Now, all these drugs take a long time, as we said, so it can take 9 months to a year to see peak effect. So I usually try to encourage them to take one of the medications. We'll try to see how much improvement they can get with that, and then add another. But sometimes patients come in and the hair loss has really impacted their quality of life, and they just want everything. So I might start one and then a month or two later start the other, just to monitor side effects and add it and just pile it on. If that's something that they have really demonstrated this is something they need for their quality of life, then we'll do it.
And who do you, like with finasteride, what are your guidelines? Do you send a note to the primary care doctor if it's a man and let them know about the PSA false positive?
That's a good question. So I counsel the patient about the PSA, but I reach out to the primary care doctor or the mental health provider for the patient if they have a history of uncontrolled depression. Because there is this question of risk of depression associated with finasteride. And so usually that's when I'm reaching out to the primary care doctor. But in terms of the risk for the PSA, I just tell the patient that whenever they have their labs tested, they should let the doctor know that they're on this medication so they know to adjust for that.
Because it can falsely...
Exactly. It can actually lower their PSA, artificially lower their
Gotcha.
PSA value, yeah.
All right, and I found that if I mention possible sexual side effects,
yes.
the men are like, no, no.
Absolutely, yeah, yeah.
So how do you handle that when you mention
Yeah.
the side effects and then they're kind of scared away from it?
Yeah, I think that it's really important that first visit before you start medications that all these potential side effects are laid out. And that's why the initial counseling of finasteride takes so long and is so difficult. Because this is a drug they might be on for the next 20 years, right? So the sexual side effects, I usually tell them it's about 3% of patients. And I tell them the fact that I am counseling you on this is putting you at greater risk. So it's actually not just the drug, it's a very complex situation. Yeah. And if you had any sexual symptoms before starting finasteride, it might highlight that and worsen it. So I tell them that usually, in my experience, patients who have sexual side effects, they notice it in the first month or two, and then we'll just stop it at that time. Occasionally, someone's on it much longer, and then they develop it, but then we'll just stop it right away.
Okay.
So.
And how do you dose spironolactone for women?
So spironolactone, if they don't have any kidney abnormalities and they're not really on any other medications for blood pressure or other medications that might interact with spironolactone, I typically would start at 50 milligrams, and if they tolerate that well for a month, then I might go up to 100 milligrams. So if they have history of low blood pressure or low blood pressure symptoms, lightheadedness, dizziness, fainting, then I might start them lower at 25 milligrams. So I would say for a typical patient who has no baseline concern, I would start them at 50, but there are many circumstances where I might start slower than that.
Okay, and then you don't go up past 200,
200 is my, max.
Okay.
I don't go higher than that. At that point, then I think either the drug's not working for you, we just have to move on to another, or it might be working for you, but the expectation is not matching what the drug can do for them. Because I usually say it's like having wrinkle treatment. You can do all the right things, but you'll still get more wrinkles as time goes on. And sometimes the expectation from patients is, I'm on treatment, I should keep growing more and more hair. But actually, you'll still, as decades go on, decline in your hair, even if you're on all the right treatments. So sometimes that's expectation management. At first, you'll have some improvement, but then it's maintenance. And unfortunately, you'll still continue to decline in your hair density as time goes on, despite being on all the right treatments.
Yeah, that makes sense. Okay, what about all the natural things that are out there that people are constantly, there's ads on Facebook and there's like, which ones work, which ones are like, don't mess with that?
Yeah, I would say, there's so many, I can't even keep up with how many there are out there. And I learned so much from my patients because they will bring the ad in and show me and say, does this work?
Yeah.
So I typically go based on what I can find in PubMed in terms of like published studies. So there is a topical caffeine in a study showing that caffeinated shampoos might have some positive effects, so I might recommend caffeinated shampoos. Rosemary oil was shown to be similar to 2% minoxidil, so you can try rosemary oil containing either topical leave-in or shampoo. Let's see, there are also other blends of herbs and things. Saw palmetto, for example, is like a botanical variant that's similar to what finasteride would do. So that could have some positive effects. The problem is you're not going to know how much you're getting and if it's a consistent dose.
It's not regulated.
It's hard to understand how much you should expect from something like that.
Yeah.
So those are some of the natural treatments that I might talk about with a patient.
Gotcha. Okay, I want to switch gears and talk about scarring alopecias. All right, so let's talk first about frontal fibrosing alopecia. So what should we look for?
So frontal fibrosing alopecia usually comes with recession of the frontal hairline. And so with that, you might notice that there's less photo damage right in front of the hairline, and there's a big break from where there is photo damage to where there isn't. That's where the hairline used to be. You're going to want to look for perifollicular scale and erythema, And sometimes you have lonely hairs there. There's hairs that are preserved, but then the rest of the hairs around them are completely obliterated.
Yeah.
So there are a lot of clues out there that can point you towards frontal fibrosing alopecia.
And is there anything we can do about it?
Frontal fibrosing alopecia is so tough, you
Yeah.
know, because what our goal here is to preserve what we have, and we're unable to get back the hairs that we have lost. So certainly there are treatments to try to slow things down and to stop that inflammation. So we're talking about anti-inflammatory topicals, including topical steroids or other anti-inflammatories, sometimes injections with steroids, and then oral therapy that might be anti-inflammatory, sometimes even immunosuppressive if the frontal fibrosing alopecia is very active.
Do you tend to hit them all at once when they come in, like they're crying, they've got like this receded hairline? So do you put them on Plaquenil and pimecrolimus, and like how many things do you do at one time?
That's a really good question. So I think that when we have someone with active scarring alopecia, we don't want to sit on that. We have to act on it so they don't lose more hair. But at the same time, you don't want to overwhelm them on that first visit. So I try to not make too many changes at once. So when they come in, it looks active, and the patient is also wanting to be on an oral medication. I might start them on one of the oral medications, one topical, and then injection. And then when they come in, which is usually, it might be 2 months later if it's really active, I might add another oral if we have to at that time. So I try to do it in stages, but you want to be quick acting if you think that it's active so that you can try to stop it where it is.
All right. Any evidence for JAK inhibitors with frontal fibrosing alopecia?
Yes, there was a case series showing that there was some efficacy of the inflammation for patients with frontal fibrosing alopecia. So that's really exciting to have another tool available to try to treat this.
An intralesional Kenalog, what dose do you do?
So intralesional steroids, I use 3 milligrams per ml of the Kenalog, and then I inject 0.1 ml, 1 centimeter apart, and it's important to go behind the hairline. If you go right where the action is, it's going to diffuse down the forehead, and we want to avoid that because there can be atrophy of the forehead. So we want to go behind the hairline, and then with a low dose, like 3 milligrams per milliliter.
And you do it how often?
I typically would do it around no sooner than 6 to 8 weeks, but really depending on what the patient needs, because usually that's in conjunction with other therapies.
Yeah.
Sometimes I need to do injections to kind of kickstart the anti-inflammatory approach, and then when they come back, they might actually not need another set of injections. So I might prepare to have them come back at 6 to 8 weeks in case they need injections. Monitor, if they're doing well, we can stretch out the visits for follow-up.
And as far as the workup, is there anything else you do, blood work, or do you do a biopsy?
So we sometimes do a biopsy. If I can't tell if it's active, sometimes I might do a biopsy. Sometimes it's really tricky. There's no redness or scale or any signs to indicate that it's active. So a biopsy is sometimes used to help me understand how aggressive do we have to be in treating this. For laboratory workup, that's really mostly geared towards the medications I'm giving them. So not for the diagnosis itself, but to treat with the medications that are available.
Yeah, it's really a scary condition when you see a patient with that.
Yeah, and sometimes they come in and it's really severe because it was insidious, and sometimes it's just not recognized as a very common, sometimes so a patient might have it for many years and it's not recognized or picked up. And so they can come in with late stage frontal fibrosing sometimes. And that's when it's tricky to know, is it still active or is this just old scarring alopecia that we actually kind of missed the boat in trying to stop it.
When we're doing a biopsy for hair loss, do you do a 4 millimeter punch? Do you put any special instructions to the pathologist?
That is such a good question because that is not going to be uniform across practices. For example, where I currently practice, the pathologists don't do Headington method, so I only do 1 4 millimeter punch. Now, if I were practicing somewhere where the pathologist felt like it was more useful to do Headington method, you might need to do 2 4 millimeter punch biopsies so they can do longitudinal and horizontal cuts. So that is maybe a conversation you need to have with your dermatopathologist that you typically work with, because the idea is to give them the sample that can help them interpret it the best they can. And so that can help inform you and the patient how to treat.
Gotcha. And if you see somebody with CCCA, do you try to do like the edge, or which part of the scalp do you biopsy?
So with CCCA, since the inflammation might be on the leading edge, that is where I would likely place the biopsy, on the edge. If you go straight in the middle of the scarring alopecia, you might miss
there.
Yeah, you just might get scar, right? And so it would be hard to inform how you should manage that patient.
Anything else for CCCA, like anything that we need to, that you wish we knew?
With CCCA, I would say one of the early ways it can present is hair breakage, which I think is, sometimes we think about CCCA and we think about that severe presentation where there's already a lot of hair loss. But sometimes it presents really early with just breakage and then just a little thinning on the vertex scalp. And that's an opportunity for us to really intervene and make a difference. Sometimes we need to do a biopsy to explore that if it's so early that you can't tell. But I think just thinking about that might help you detect it when it's early.
And your slide of the treatments, it looked very similar to frontal fibrosing alopecia.
Yeah, that's
like
right.
You still did the intralesional Kenalog or
Yes.
steroids. You still did the anti-inflammatory topicals.
Right, exactly. So actually, my colleague and I, we always think about maybe CCCA is an extension of LPP or lichen planopilaris, because they both can be considered lymphocytic inflammatory hair loss. And so the target is similar in that way, that we want to decrease that lymphocytic infiltrate. And I think as a result, the treatments are very similar.
So doxycycline possibly,
Yes.
hydroxychloroquine.
Exactly. And then sometimes we use anti-androgen treatments, so like finasteride or dutasteride. Sometimes you might throw in oral minoxidil to try to maximize the hair they have. Not really to, that doesn't really combat the underlying inflammation of CCCA, but it can just help the patient.
And lastly, alopecia areata.
Oh, yes.
So now that we have JAK inhibitors, how have you seen that transform your treatment for alopecia areata?
Oh,
that was
it's
a
just
leading
been
question.
Yes.
Sorry. Go ahead.
Yeah, it's just been amazing. I mean, until 2 years ago, it's just hard to imagine there was absolutely not a single FDA-approved treatment. And now we have something available that patients who didn't have hair for the last 5 years now have something that can help, help them get their life back in some ways. So for patients who we can get insurance coverage, who are good candidates to start, and they tolerate the medication, it has been such an amazing part of, a rewarding part of my practice to see patients coming back. And it's amazing to hear what they're engaged with in their social life now, how they're doing professionally. They come in with accessories and makeup. You can tell that their confidence has come back once that they get their hair back. So that's really amazing as a clinician to see.
And in a very short office visit, how do you quickly tell them about a JAK inhibitor?
Oof, that's really hard. So sometimes it's a discussion that happens in phases. So sometimes we get things going, we check labs, and if we're really running out of time, I might start them with, this is some initial reading you can do, you can look into it, and I'll have a soon appointment for them to answer any questions. But it's really hard. This is a powerful drug, lots of potential side effects. You can't really be rushed into starting it. So, and the other thing is, it's sometimes a journey with insurance. It could be weeks going back and forth whether or not they're going to be able to have it. So sometimes you can stage it in that way. You can say, let's see if your insurance will cover it. Here are some of the side effects. Let's get some initial workup. And then when you have them come back, then you can talk more about, is this the right option for you? And is it even an option for you? If insurance didn't even cover it, then we have to think about other ways.
That's wonderful. Is there anything else that you wish PAs, excuse me, or providers knew before they did a workup for patients with hair loss?
Well, I would say that one of the most important things about treating patients with hair loss is just understanding that it's really challenging for everyone treating this. And even though I've been doing this as a specialty for over a decade, I'm so humbled by all these hair loss conditions. And it's just really challenging. So sometimes even acknowledging that as a clinician, this is really hard, is helpful. Take a deep breath, and then also try to understand the impact that this has had on the patient. Because a lot of times we try to rush in and we're thinking about how do I get those follicles back? But really also addressing the emotional burden the patients have had, the loss of identity, sometimes self-esteem, the feeling like they haven't been doing well professionally or socially, and acknowledging that to the patient is really helpful for the patient and for the clinician. Then you can really build that bond, and it helps moving forward for managing their hair loss.
I love that. Thank you so much for sharing with us today, Dr. Huang.
Thank you for having me.
Yeah. Hope Cook signing off with Dermcast Live.